Welcome to AETCM, the emergency medicine channel.
Yes.
35-year-old male who came to ER with complaints of transient loss of consciousness for about 10 seconds, which occurred about 15 minutes back. On initial 10-second assessment, the patient was conscious oriented. He was talking in full, complete sentences. And on primary survey, the airway was patent. There was no pooling of secretions or stridor or any gurgling of sounds. And breathing, the saturation was 97% in room air, and respiratory rate was 18 per minute. Air entry was bilaterally equal, and there was no presence of any added sounds. Circulation, the heart rate was 70 beats per minute, and BP of 130/70 millimeters of mercury. And all peripheral pulses were palpable and equal, with a capillary refill time of less than 3 seconds. And disability, the GCS was full 15/50, and the pupils are equal and reactive of 2 mm. And the exposure, the temperature was febrile, and the GRBS was 130 milligram per deciliter, and there was no presence of any rashes or bleeding spots, and there was no smell of any alcohol, any other substance use. And as adjuncts to the primary survey, we had taken an ECG. ECG had shown a normal sinus rhythm with a QTC of 455.
Okay.
And we had also taken a blood gas, venous blood gas, which showed no acidosis or alkalosis. And
what are the abnormalities you look in ECG? You can get in ECG in the case of syncope.
In case of syncope, there can be syncope can occur due to a cardiac cause. So that one mainly due to a dysrhythmias.
Okay.
So it can be due to a tachyarrhythmia or a bradyarrhythmia. So in presence of tachyarrhythmia, like in supraventricular tachycardia or paroxysmal tachycardia, or in the case of even atrial fibrillation. So even in like WPW syndrome.
Yeah.
So VT, torsades pointers. Okay. So and atrial flutter. So such tachyarrhythmias can also cause.
So basically, you have to check for any arrhythmogenic conditions are persisting, like Brugada pattern. This WPW syndrome, short PR interval. Yes. Then atrial fibrillation. Yeah. So anything which can prompt to arrhythmia, that is very important. Okay, because most of the tachyarrhythmias, when the patient come to ER, you will not see anything. That might be a paroxysmal rhythm abnormality. Okay.
And even in case of bradyarrhythmia, it's also bradyarrhythmia can be also as in case of short or long QT syndromes, as in case of sinus node diseases or first degree, second degree, sixth sinus syndrome, or second degree heart blocks. Or even if patient is on a pacemaker, the pacemaker malfunction can also lead to syncope. So these are the different cardiac causes which we have to rule out and can be seen as a significant finding in the ECG.
What cardiac condition will produce positional syncope? Some position they develop syncope, some position they will become normal. HOCM, post-exertional syncope.
Yes.
That is dynamic change.
Or an aortic stenosis.
Aortic stenosis is also exertional syncope. What is that condition? Patient can have syncope on standing posture, but it is a cardiac condition. It's a rare cardiac condition, not very common. Left atrial myxoma.
Okay.
So when they stand up, that myxoma will close the valve. Okay. So that is a very important, but it is rare condition. Okay.
So again, after we had taken the ECG and venous blood gas, after that we had again taken a BP. We had taken a supine BP, and we had also taken standing. BP. At 1 minute and at 3 minutes, we had taken intervals.
1 minute why you are taking, 3 minutes what you are looking. 1 minute what are you looking, 3 minutes what are you looking?
Usually, if patient is having we are suspecting a possibility of an orthostatic hypotension. That is usually a fall in the systolic BP more than 20 millimeters of mercury, or a fall in the diastolic BP more than 10 millimeters of mercury while standing.
That is postural hypotension.
Yes.
What are you looking in 1 minute? First 1 minute.
1 minute.
Since you told, I am asking a question.
Yeah.
What are you looking?
It's any peripheral neuropathy that patient has to.
No, he is checking BP and pulse in first 1 minute and 3 minutes. What is that condition? Postural hypotension is 3 minutes.
3 minutes. 3 minutes.
Yes. POTS. What is POTS? POTS. Postural orthostatic tachycardia
Tachycardia
syndrome.
syndrome.
Some patients will not have hypotension. Some patients only will have tachycardia on standing. Immediately on standing, patient will have 25% extra heartbeat. That patient will have pre-syncopal attacks. Okay. So that is POTS. Okay.
So after that, we had moved on to the secondary survey, and we had asked for the sample, the history. The patient was a 35-year-old male, known case of type 2 diabetes. He came to ER with a history of a transient loss of consciousness of about 10 seconds, which occurred after 3 bouts of cough after getting up from bed in the morning.
But you told his blood sugar is 134. Can patient develop syncope at that blood sugar?
No.
Yes, sir.
No. No.
Normal person? No. That is correct. But in a hyperglycemic patient, continuously if the blood sugar is very high, like 200, 300, suppose that is a normal range for that patient. If the patient develops a minimal hypoglycemia, like 135 is a normal for a normal person, but for him it can be hypoglycemic episode. So that type of patients may go to hypoglycemic symptoms, pre-syncopal attack. Okay. So the average sugar value is very important. Okay. Some patients even on 130, 120 itself they'll show the signs and symptoms of hypoglycemia.
And it was we witnessed episode by the bystander. So like bystander had this episode of consciousness and fell onto the bystander.
Okay.
And
After severe cough, she fell down.
yeah, he fell down. And there was no history of any frothing of mouth or the tongue bite. There was no presence of any tonic-clonic movements or any posturing. There was no presence of any urinary or fecal incontinence. And also there was no presence of any confusion post the event.
So that all rules out possible
Seizures.
Yes.
Okay. And there is no history of any like fever, no fever associated.
Why fever in history is very important here?
In case of
Fever. Fever produces what? Postural hypotension.
Postural hypertension can occur.
So that is very common. High degree fever, most of these patients fall down because of the postural hypotension, dehydration, intravascular volume loss. Okay.
And there is no history of any chest pain, or any palpitation. There was no presence of any sweating or orthopnea PND post the event of the syncope attack. And there is no history of any weakness of limbs or any slurring of speech, facial deviation, and there is no history of
rule out stroke.
Yes, and there is no history of any headache or there is no history of any nausea or vomiting.
You can rule out migraine.
Migraine attack.
Can migraine produce loss of consciousness?
Yes, sir.
It can produce all neurological symptoms, including visual loss.
Yes, and there is no history of any abdominal pain or pain radiating to the back.
Okay, what you are suspecting when you are taking that history?
There are 2 possibilities. One, in the case there could be a possibility of an abdominal aortic aneurysm. In pregnant females, there could be presence of a ruptured ectopic. And the patient had 2 similar episodes in the last 1 month.
Okay.
Similar episodes. One episode was while he was passing urine. The second
micturition
syncope.
Okay. Both mechanisms are different. Micturition syncope mechanism is different from cough syncope. What is micturition syncope mechanism?
Micturition syncope is by the loss of the bladder tone.
Loss of the bladder tone.
Sudden
evacuation of urine.
So what will happen? Suddenly, when the bladder was full, suddenly evacuated that. So there will be a negative pressure in the abdominal compartment. So that will draw more volume in the IVC. So blood will not flow to the heart. Okay, that's why they develop syncope. In cough,
Increasing increase.
there also negative pressure will increase. That means it will go more and more negative.
Right.
So again, blood draw will be in the thoracic compartment of the IVC
And reduce cardiac output.
output.
There is no history of any breathing difficulty also associated for this patient. And we also asked him the allergic history. He's not allergic to any drug. The medication history also we had asked him. He's just using tab metformin
Total medication history, you want to confirm that this patient, when somebody develops syncope.
We must ask about the usage of any beta blockers.
Beta blockers normally will
Or alpha blockers.
Where exactly which condition? This is male or female?
In BPH.
So you have to
BPH
specifically ask whether the patient is taking any BPH medications or not.
Yes.
Alpha blockers are the one which produces severe postural hypotension.
Yes. And even usage of nitrates.
Nitrates. Okay.
Nitrates are also causing orthostatic hypotension. And then we are moved on to the physical examination. On examination, patient was initially conscious and oriented. With the CVS system, the patient S1, S2 was normal, and there was no presence of any murmur. And we also checked.
What murmur you want to check? You want to look in which chamber of the heart here?
Want to look for the aortic
stenosis or subaortic stenosis or HOCM
murmurs. And also look for the carotid bruit, which is present. There was no presence of any carotid bruit. And CNS, there was no, the power of all four limbs were equal. The cerebellar signs were also negative. And Romberg's test was negative. And there was no presence of any other focal neurological deficits. And per abdomen was soft. There was no presence of any tenderness. And there was no presence of any signs of like external discoloration in the abdomen. Like as we can suspect in a ruptured ectopic, there couldn't be presence of any hemoperitoneum or something. And chest also was clear. There was no presence of any decreased breath sounds or any added sounds. So then we
possible diagnosis of cough syncope
was what we made.
What advice you? So we cannot treat this patient. Patient had syncope is absolutely normal. What advice you should give to the patient? What all advices you can give to the patient?
It's always give for the like we should just ask for any change in semiology, like for the if what other factors could be the trigger.
No, it's a cough and syncope.
Yes.
First of all, you have to suppress the cough.
Yes.
Okay.
Yes.
You give cough suppressants.
Yes.
Tell some cough suppressants.
Dextromethorphan,
codeine. Okay, so that can be tried. Yes. Then, if patient develops cough, what you will advise? They will have cough now.
Yes.
He cannot completely stop it. What you will advise?
Make sure sit in the sit.
Make sure that they are sitting.
Sitting.
Whenever patient getting severe cough, violent cough, better to sit. These patients repeatedly they can have same problem. Okay, it will be very difficult to treat these patients. Whatever treatment you offer, they will not improve. Okay, because it's a basic problem inside their body, physiological problem.
Yes.
They have to understand that. They have to train for that. What happened to the patient afterwards?
This patient then he was found symptomatically better. We are also done a screening echo also for this patient.
Okay.
It was found to be normal. So then we are discharged this patient and advised for further alter monitoring and cardiac evaluation.
Okay. Alter monitoring is done for what?
We should look for if any underlying arrhythmias were associated or not.
Okay.
And so usually in case of syncope. So syncope is usually a brief period of loss of consciousness with an inability to maintain the postural tone. So that's usually spontaneously resolves without any neurological.
That is very important. Patient spontaneously recovers from the position or condition. That is very important.
Without any medical intervention. Yes. And there is no presence of any baseline. It comes back to the baseline neurological condition. There is no presence of any neurological deficits post the event. And there is also a condition called as near syncope or pre-syncope, in which there is a premonition of fainting, but there is no history of loss of consciousness in that individual. And the pathway is usually there will be a complete disruption of the blood supply for a short duration of usually less than 10 seconds to both the cerebral cortices and to the brainstem reticular activating system. And also a reduction to the cerebral blood flow by 35 to 50%. So that's usually the mechanism. The most common causes of syncope, according to the Framingham heart study, it's usually the most common is a vasovagal. So that is
severe pain,
anxiety, causing an autonomic dysfunction leading to syncope is the most common.
There also vasodilatation is most important, and bradycardia can also occur.
And that can be cardiac cause. Cardiac cause is the second most common. Then can be orthostatic or medication related or neurologic, and unknown is the most common overall. And cardiac syncopes are mostly one of the most dangerous. They have almost 100. There's increased chances of death, double the chance of risk
What
of
is
death.
Brugada syndrome?
Brugada syndrome. There will be the presence of
What is Brugada?
long QT.
No, Brugada is not longevity. Brugada syndrome is one of the common, it's not common, one of the major cause for death, sudden cardiac death. That if you see in the ECG, V1, V2, you can see RSR-like pattern with ST elevation with T inversion. Okay. So that patterns, there are 3 types of Brugada patterns. If that pattern is seen in this type of patients, you have to check whether the patient is having Brugada syndrome. That is tachycardia, sudden cardiac death, family history of sudden cardiac death. These things are very important. Okay, so we have to always look for Brugada pattern in ECG in this type of patients. You may misdiagnose it as RBBV.
Oh.
Okay.
Yes. And so these are the different causes, and then usually in cases of vasovagal syncope, there is less chances of death, mortality. And usually the causes of syncope can be divided into cardiac and
normally syncope occurs in standing posture. Patient falls down, patient regains consciousness. Which condition patient develops syncope on lying down posture? Syncope by definition it is like this.
Yes.
Which condition patient develops syncope on lying down posture? Second degree and third degree heart
blocks.
What is Cannon verb in your JVP? Cannon verb. Might have learned all these things. Both atrium and ventricle beats simultaneous at same time. So what will happen? There will not be any effective pumping during that period. So if a patient is having complete heart block and high grade second degree heart block, so both atrium and ventricle may act on same time so that the valve will be closed, but unnecessarily ventricle will be pumping, nothing will go out. So that patients can go to syncope. Okay. Cannon wave is a clinical finding. You can see very huge waves on the neck. At that time both atria and ventricles are pumping together and both the valve will be closed. Okay, so patient can have syncope on lying down posture. So that is very important. Whereas other tachyarrhythmias may not have syncope on lying down. They have discomfort and palpitation and all these things.
So the usually the cardiac causes again divided into two: the structural heart disease and dysrhythmias. So the structural heart disease usually involves the valvular heart disease, as in case of aortic stenosis, tricuspid stenosis, mitral stenosis, cardiomyopathy. So pulmonary artery hypertension, and even the presence of atrial myxoma, pericardial diseases.
So atrial myxoma is very important. On one position only they will get. That is positional syncope.
Positional syncope. And pulmonary embolism.
Pulmonary embolism, how do they present syncope?
They will present with shortness of breath.
Syncope. You have told pulmonary embolism will produce syncope. That is correct.
Yes.
But you should know the mechanism also. What happens? Massive pulmonary embolism obstructs the pulmonary vasculature, so that from right ventricle nothing will go to the left ventricle, so that left ventricle is empty. So patient develop syncope. So if that condition occurs, hypotension syncope, then this patient must be taken for thrombolysis. Thrombolysis or something else. Thrombolysis can be done, or you can take the patient for embolectomy. Okay. Thrombolysis is the choice in most of the hospitals.
And even a myocardial ischemia, myocardial infarction, and dysrhythmias usually, as I mentioned before, it's usually the bradyarrhythmias or the tachyarrhythmias, and the next one is usually the neural or reflex mediated. That usually involves the vasovagal syncope, and the situational syncope. Situational syncope usually involves the cough syncope, micturition syncope, defecation syncope, swallow syncope, and even then carotid sinus syndrome.
How do they present carotid sinus syndrome?
Carotid sinus syndrome is usually seen in patients with carotid hypersensitivity.
How do they present it?
They usually have an episode while shaving or like
mostly either while cuffing the collar or shaving. Okay.
So that time they usually present with syncope. And another possibilities are also orthostatic hypotension as such. And then next is in case of psychiatric illness. So there can be psychogenic factors which is involved in syncope. Malingering. And then in neurological factors, yes, plain like in TA or in presence of migraine, it can be present, and in children, as in breath holding spells, also it can be present. So usually we must on case of
seizures, one example, typical example for syncope. Suddenly they'll fall down. We'll misdiagnose it as syncope.
Yes. And we should always look for, in case of syncope, the signs of instability. So that are usually the signs we should look for in case of syncope. As in patient is having a hypotension, or a patient is in hypoxia or not. A patient is having any chest pain or any altered mental status post the syncope event also, and pre and post. And we must look whether the patient is in shock or any presence of heart failure is there in this patient, and whether the presence of any unstable tachy or bradypnea in the patient is present.
What is tachybrady syndrome? What is tachybrady syndrome? Six sinus
syndrome. Yes.
Sometimes you can get tachycardia. Sometimes you can get bradycardia. Tachycardia means it will be very fast. Bradycardia means it will be very, very slow. So both time patient can have syncope and pre-syncope, cardiac failure, everything.
Yes. And so usually if patient is having a pain abdomen with the syncope, we must always look for an abdominal aneurysm. So there is also a syncope scoring system to look for whether patient should be admitted or discharged in the patient. That's called as a San Francisco syncope scoring system. So that it is of a mnemonic CHESS, CHESS. So it is C is presence of any congestive cardiac failure is present or not. H is usually the presence of a hematocrit. Hematocrit is less than 30 or not. And E is usually the ECG changes. S is usually the shortness of breath. And another S is the systolic BP less than 90 millimeters of mercury. So if on any one of these factors are present, patient requires admission. So that is how.
Okay. What is HOCM's typical feature?
HOCM will have a murmur.
Murmur I am not asking. What timing of syncope? HOCM.
On exertional syncope.
What will happen to the heart on exertion? What is SAM? SAM. That is systolic anterior motion of the ventricular wall, free wall. So when there is exertion, this subaortic area, anterior wall will move forward and block the aortic orifice. Okay. So during exercise or immediately after exercise, they develop syncope. That is a typical feature of subaortic, that HOCM. HCM and HOCM both are slightly different. HCM is hypertrophic cardiomyopathy. Hypertrophic obstructive cardiomyopathy, they have syncope and other features. Whereas aortic stenosis, they have syncope during the exercise. Other one, after strenuous exercise, they develop syncope. Here, during exercise itself, they will develop syncope, severe aortic stenosis. So there are slight differences between each condition, but ultimately they all produce syncope. Anything else you want to add? Nothing. Thank you.
Okay, thank you.